Hey guys, it's Natalie, and this is the Health Tech Hot Seat. My interview today is with my good friend Dr. Ken Nepple. He's a urologist and surgeon at Iowa Health, and he also serves as the Associate Chief Health Information Officer. He's also an informaticist and educator, truly at the bleeding edge of what's next in clinical AI. I hope you enjoy our chat today, coming from the front lines of what's really happening in healthcare AI. We are here with the Health Tech's Hot Seat, guys. Natalie, live from HIMSS 2026. I'm here with my good friend Ken. Ken, you have such a wide variety of experience. First of all, you're a urologist by training, and not just any urologist, but you have a surgical aspect to your urology care, and even in the cancer setting as well, correct?
Correct. Yeah. I think that's part of it is still having that boots on the ground, taking care of patients, trying to be efficient, working around residents, doing education, trying to innovate at the same time.
So you're really seeing kind of all aspects of that clinical care, outpatient, right? Inpatient rounding, OR, and teaching.
Yeah. And I think urology, like there's probably several specialties like that, but
Sure.
we get, access to patients everywhere. There's
Yeah.
inpatient, there's high volume outpatient, there's emergency room. Occasionally we've got, ICU covered. We're covering a lot of call. And so there's just all the aspects of trying to figure out how to do all of that and make the system a little bit better to help you out rather than, sometimes hurt you.
Yeah, absolutely. And then outside of your clinical care, you are an informaticist as well. So tell us about that.
Yeah, I think my journey in informatics started with just somebody in my office in around 2014. Made some complaints about the EHR, and they said, "Well, actually, we can make this better." His name was John Gravel, and he was working with the EHR team. Had spent kind of 4 years working previously at the vendor, and so then we redesigned the widescreen navigator, and that got us. Sort of access to the system, and then with those improvements, presented that to our hospital team. And back then, it wasn't clear that like informatics was a thing.
Cool. Okay.
And so started to work with that team in a supported kind of assistant CMIO role. And then just worked on making things better, and then kind of stuck with that over time, and recently transitioned into kind of trying to specialize a little more in the cancer center space. But
Oh, really?
yeah,
And
yeah,
like from an informatics lens?
yeah, and I
Oh,
think it was
cool.
partly your what's your expertise, but then also where do you add the most value? And
Yeah.
so like if it was a pediatric workflow, I'm like I kind of knew what was going on, but I'm not like in that situation. And then it was identified that the cancer center had some specific needs, and that includes seeing patients that are very complex, which is probably true of everywhere, but especially at a cancer center, they're very complex. How to ingest all that information, get it to the providers, but then especially how do we work in other spaces like clinical trial matching? What can we do with technology to improve things in that space? And then I think it also combined with just having a really supportive environment. And we've got a good group to work with. We've got great people in informatics. And then we've over time, developed some great partnerships with vendors and different software products and really trying to say, what's the best EHR suite of products, including AI products that we can give to people and help them to make their work a little easier. And then ultimately to provide the best possible care for patients and always trying to keep an eye on the lens of, well, what's this like for the patients, and
Yeah.
how can we do things that are informatics but also patient focused.
Yeah, I went to a really interesting talk yesterday, and it was like all about reframing whatever product or solution you're trying to implement, like from the vendor and from the health system side, as it's always a patient experience problem or solution,
Yeah.
right? And so, like, what does it look like to flip the script on talking about value, with
Yeah,
patient experience?
absolutely. And we've tried to kind of walk those different lines of like uh, clinical stuff, surgical stuff, but all being, patient focused. And so we had gotten some support to use an embedded AI kind of clinical data intelligence system that we have in place to do some prostate cancer quality improvement research.
Nice.
And then we're working on that, but then submitted for a different bladder cancer grant and got the feedback of like, well, where are the patients at in
Yeah,
this
yeah, yeah.
experience? And so then like read that feedback and then looked back through or thought through what I had written. And I'm like, yeah, that's right on.
Yeah.
And so literally that day, I'm like, oh, why don't I make a prompt in our system that is a patient focused summary at sort of a sixth grade. I'd heard that term in the past, sixth grade or below, reading level that could be given to the patient about their, well, either prior history or their encounter. And then on the spot, it kicks out a summary. And then, that was a little bit generalized. And so then I said, well, okay, now make a summary number two that uses medical terms, but defines them every
Yeah.
time. And I'm like, okay, like that's a good one for the patients. And then in the back of my head, I'm like, all right, now make a third summary that's like the engineer
Yeah.
who wants like all the detail, and so literally in 15 seconds, the idea pops in your head. And then within 5 minutes, you've got something in front of you.
Yeah.
And then started to show some of those to patients. And then we're kind of trying to think about how we can evaluate that, study that, and then, semi automate it.
Mhm.
So,
Mhm.
I'm not at the end of a visit going to type out every time, or pretty much never.
Sure,
I'm
sure.
not going to type out a summary for the patient,
Right, right.
but it's actually pretty easy to review that.
Sure.
And then, throw it on the after visit summary, or, more and more, it's clear that patients are reading notes.
Yeah.
But do they have a section that says like, hey, this is the part for the patient to read?
Yeah.
And
Yeah.
so I think there's some ability to, uh, work on stuff and like innovate pretty easily in that space without spending hours and hours on back and forth conversations
Right.
with
Between the
something.
clinician, the
Yeah.
physician, and informaticist back. So, like to that example, what were you using an internal LLM that was kind of like safeguarded, or were you, kind of scrubbing some free text of PHI, and
Yeah.
how does that work?
So no scrubbing, but we have a solution. So we use the Evidently platform.
Okay.
So that's clinical data intelligence that kind of summarizes in more of the chart,
Mm-hmm.
but it ingests the data, processes it, kind of maps it to a knowledge graph, and then is available for either providing summaries
Mm-hmm.
or for prompting. And so we had access to, and I guess me personally in a small group had
Mm-hmm.
access since about January of last year with doing prompting. And so
Mm-hmm.
the first run of that was, do you trust the output?
Sure.
And if we don't trust it, well, then we don't turn it on. But what realized like, okay, the output is pretty good. And then you could really evolve your prompting, just like people are doing in different spaces,
Yeah.
to be more and more specific with the output in what it's giving you. And so that's still all embedded within the EHR. And so I didn't have to worry about like jumping into a separate product
Sure.
outside and scrubbing.
Yeah. It's all like a safe sandbox, so to speak.
Yeah, and it's also super specific for that patient. So it's
Yeah.
already
Mm.
seeing all that summary is based on the data that's coming back, and
Mm-hmm.
then the cool thing you see is okay, like CT reports not back. Then once it's back in real time, that summary updates.
Updates. Yeah.
And we've even the other day I heard somebody talking about like, okay, can LLMs or AI in general look at the chart and like find problems and find inaccuracies because
Mm-hmm.
we know they exist within the chart. And I'm like, oh, that's kind of a big thing to take on.
Yeah.
But I said, well, I could do that for my patients in my notes. And so
Yeah.
I just wrote a prompt, which is, like find two errors or inaccuracy in the last Dr. Nepple note, and then, surface those. And if not, provide some example where like education could be added to the note to help. And so turned it on, and the first one it saw was, oh, patient's going to return in January of 2025. So it had the classic like year is
The
wrong
year was
that
wrong.
somebody had just
Yeah.
typed the wrong year.
That's me every single
Yeah,
January.
yeah, it's
Yeah.
like January and February,
Like,
sometimes into
oh
March.
yeah.
So I'll joke with it. I catch a lot of those, but our residents,
Sure.
I'll be like, I'm like, are you oriented to year?
Yeah.
Uh, and
You're only ANO times two, dude. Yeah.
yeah,
Yeah.
and then the other one that I remember was occasionally somebody will misspell my name, and so it said,
Got you.
you'll see Dr.
Doctor.
Nipple,
Uh-huh.
and
Uh-huh.
so it said like, oh, we think they mean Dr. Nepple,
That's
and so then I fixed it in the note, I signed the note, and I went to screenshot it because I'm like, that's pretty funny, and then in real time it disappeared because the chart had note had updated, so it's like that's
Ah,
not a problem anymore.
there you go.
Yeah, and so luckily I'm not finding a lot of errors in my notes, but
Hmm.
it will provide like an example of like, oh, you could do more education about this or that. So
Yeah.
it's not that like right now I'm doing that in every note, but
Hmm.
it's really like, can I get insight into what does this system see about this patient?
Sure.
And then is that trustworthy? And then is there a way to use that for specific patients? And then over time, there's been more and more patient summaries that are out of the box
Hmm.
available that you don't have to prompt for,
Hmm.
but to be able to provide that feedback of like, oh, this is a pretty good prompt. And then there might be providers that want to do the prompting, but you can also potentially, work in that prompt to show a patient one liner or
Yeah.
show some sort of summary. So
No, that's so interesting. And when you get to those kind of solutions that allow you to like play in this safe sandbox,
yeah.
we were both at a session yesterday, and you asked a really great question. I want to get back to that, but I think that the opportunity for clinicians, physicians and APPs and nurses and all kinds of people across the spectrum to really learn how to prompt well
hmm
in a place where we have access to patient data, then to create, your kind of your own solution, right? Like at the
Yeah.
point of care. And that's I think that that's like the future of innovation. But I'd love to hear your take on that.
Well,
And
and I
then
and I think an element like I don't have any solution for like burnout, and I don't want to like
yeah,
underemphasize burnout because I think that's a real thing and it's existed forever. But I think there's a component of that. It's that you're in a system that you don't control and that you can't really make edits to in real time.
sure.
And so it's like you're stuck in this box. And so I think these sort of things provide for people that are motivated to use them
Yeah.
the ability to really make the system match your needs. And so, yeah, and then it's funny, like, I'll keep an eye out on LinkedIn or like look at YouTube videos. And then now I'm like, I don't pay attention as much for some of those videos with like what's happening in healthcare,
Mm-hmm.
but it's like what's happening on the coding side of things
Hmm,
with
okay.
software engineers
Sure.
because they're going to be out in front of us. And so, it's like for a while everyone's talking about prompt engineering, and then okay, now it's transitioned to agentic workflow,
Yeah.
and they're pretty similar. Like you need a prompt to tell something to do something for you, and I'm always big on humans still in the loop, but I think as you develop that skill set, there were like 2 months where I'm like, everybody's going to prompt, like this is the answer.
Yeah.
And then I went around talking to people. And then at the end of that, I'm like, not everyone is going
No.
to prompt
No.
because people don't necessarily want that. So I think you'll
Yes.
have like you and me and other folks, you might have 10% of the population's like, okay, we're going to do all this prompting.
Hmm.
But now I've kind of transitioned into, okay, then I can either, right now share those prompts with partners
Hmm.
that are in, or, our urology group, our residents are really running with it. But then over time, it should be that the system knows the context of who you are.
Yeah.
And if you're asking a question once, well, it should sort of know, then you probably care about that thing in the future.
Yeah.
And so I think we'll get to probably, depending on what tools people have access to, I think we get to that context in the chart sooner, maybe than some people are expecting, just because we're already seeing that with this tool that does a really good job of seeing the patient,
Yeah.
and then over time is doing a even better job of like seeing me.
Yeah.
And so it's not like well, do you want a urology template? I'm like, for a note, I'm like, all right, that's like something. But then like, all right, do you want a Ken Nepple template? I'm like,
Right.
all right, that's what I'm looking
That's what
for.
you need.
Like I want something really specific because not everybody agrees with the same things. And
Sure.
so the systems are smart enough and fast enough now to where you can move things in a much more malleable fashion
Yeah.
and do it in your head on your keyboard without having to explain what you're thinking to other people, and then have them give you the version of
What they think that you
of
want.
this
Yeah.
the tire hanging from the swing is like the
Yeah.
classic one of okay, you're asking for this, and then you get something entirely different.
Yeah.
And so despite like the best informaticists still don't know how to read my mind, and
Much to your
and I
chagrin.
still sometimes don't know how to read my mind, but you can evolve that, and it's much easier to see the output. Say, oh, this is missing or hitting, and then do that, pretty efficiently now.
Yeah. That's a really interesting take. A lot to unpack there. I wonder what, in your opinion, is the future of education
hmm
within a health system when it comes to like enabling our staff to do what you're doing. No, number one, I agree. I think that people have prompt fatigue. That's what I'm calling it. You
Yeah,
can steal that
yeah,
term, by the
yeah,
way. Prompt fatigue. You heard it here first.
yeah.
But it's like, so, but then outside of prompt fatigue, how are we as a health system? You can talk about Iowa Health
hmm
but how are we equipping people with education that can enable us to use AI in a way that's actually effective, right?
hmm
And safe.
Yeah, yeah, and yeah, it's funny. Like, I coined the term in my head, prompt anxiety too,
Yeah. Oh, that's
which
a
is
good
like
one. I
I
haven't
have
heard
a
that.
prompt that
Yeah.
creates great output, but then I worry that it's going to stop creating the same output as the model updates. And
Sure.
so that seems like it's not an issue. But um, for us, education is really central. Like, the dean of our medical school, on the student side, he's a pediatric urologist. He was like a mentor for me when I was a medical student back in the day. And we're always thinking about our students. We're thinking about residents. The approach that we have taken is that our College of Medicine has said, okay, individual rotations can decide what students are getting access to or
Mhm.
not. And even within our department, like at a faculty meeting, there were some people that felt like, oh, they shouldn't use any AI tools. And then I'm like, well, if somebody's spending a day with me, then like we're going to show them
Yeah.
potentially, how we use tools. They may not be using them as much themselves, but I think it's really providing a spectrum of experiences for the different students, for the
Mhm.
learners. Um, Realizing we're trying to rapidly upskill people and we don't
Yeah.
want to add something that's going to deskill, people. And so the other odd thing is like, okay, who needs education? Is it actually my fellow faculty,
Yeah.
or is it the students who need more education about what AI can do? Because, I'll tell them like, oh, you should know like there can be inaccuracies or confabulations, hallucinations, whatever you want to call. And they're like, yeah, yeah, we know that. Like that's how these, all the LLMs work. And so they're pretty aware of that. So we actually have a pretty supportive environment. There's like a GME, our graduate medical education, like innovation awards. We wrote something up with our residents, and then basically have had a couple of educational sessions where it's like money for food, and it's
Yeah.
like, all right,
Sure.
we're
There you
gonna
go.
we can get everybody there
Yeah.
by having food available. And then we had one sort of meeting where we just talked about, hey, what are people thinking about in this space? And then we reached out to one of our partners, evidently people, and I
Uh-huh.
said, hey, can you put somebody like one person on a Zoom? And then they had 7 people show up on the Zoom,
Cool.
which was cool. And then I just kept my mouth shut. And it's the residents asking them questions, them asking the residents questions. And then one of our residents who's actually here at HIMSS,
Okay.
that's how we roll at Iowa, is we
Yeah, I
bring
like
our
it.
residents too. Then he had prepared some slides, and we thought, oh, everybody will log off. But then the folks from their team are like, oh, we want to listen to what you guys are talking about too. And so kind of engaged them with that. So then now we've got, in about 3 weeks, we're going to do a symposium, just an hour and a half for all of our residents across all of the different residencies. And we
Nice.
have a space like right off of football stadium.
Nice.
And then we got a bunch of food, like a
Yeah.
lot of food.
So you
Uh,
hear it here first,
yeah,
guys. If
yeah.
you're a resident at Iowa
At
Health,
Iowa, yep,
come
we're
on
getting
over.
getting the word out. And so
So there was an
uh,
interesting thing at Stanford. They told me that they have kind of a setup, and maybe this is one specific department because it was a radiology attending who was speaking, but that they have, you actually are not enabled to use some of their AI tools unless you've done education.
mhm.
What's your take on that?
Um, I think it's a necessary component to understand the tools.
Sure.
How much you need to build that in or not, I think is a little bit debatable. We had a summary tool in place. Then once we added sort of the advanced features, which are sort of an ask, like conversational part of it,
Mhm.
and AI kind of custom summaries, which is the part that I use a ton. And then also note drafting, then it was built into that model to have like an 8 question test. And I don't think anyone has ever failed the test
Yeah.
because the points are pretty clear.
Hmm.
But I think there was a desire from folks to have some documentation that people understand
Sure.
that the tools can have errors or inaccuracies, and that also, depending on the patient, what is it going to see?
Sure.
And for us, that's actually most pronounced with health information exchanges, because there are different institutional settings about what is prefetched for patients.
Okay.
And that's from the vendor side at the institutional level, what people are deciding on. So I actually had 2 separate conversations during this meeting by email with different groups. And so you have either, okay, none of that data loads,
Uh huh.
or you have all that data loads, or an in between. So we're an in between place. And it sounds like there's only one place in the country that does all
All
of
of
the
it.
data load just
Interesting.
because the compute is so high.
Yeah.
And
Yeah.
so we were talking with an outside group, and they were a nothing loads unless you manually click the refresh button or
Mm.
the load button. And so we kind of fed back to them with, oh, you should try to consider this middle.
Sure.
But then we're re-educating our providers periodically with like, okay, if you're not seeing what you want to, or, it's a little weird to tell people like, all right, your workflow can be go into the chart and then hit this load button because you think, oh, if you go to the health information exchange tab, that should be a reason to load the
That's your
data.
data. Yeah.
But
Yeah.
but when you go to that tab, it's actually just seeing the data. And so
Mhm.
there are some of those parts like that's how the vendor product is
Yeah.
versus like, okay, when we do summaries, those are actually loading in real time. So
Yeah.
if somebody's report from their CT comes back and you have a summary of the visit, like that's loading in
Yeah.
real
In
time.
real
So it's
time.
just
Interesting.
knowing, and
What your
literally
data flow
nobody
is. Yeah. Yeah. What you're
knows
doing.
like all the points of that,
Sure.
but just recognizing like, okay, if something's missing, then that's something that like, oh, you have to go to this space and load this data.
Yeah. No, that's a really important point. Okay, I've got some heavy hitter questions. Are you
All right.
ready?
Yeah.
All right. It's Dr. Ken Nepple. We're here with the Health Tech Hot Seat. You said healthcare AI should be the opposite of you get what you get and you don't throw a fit. Okay? You
Yeah.
wrote that.
Yeah. I might have wrote that.
So what should we be throwing fits about?
Well, I think you caught me on the spot. I don't know what I was thinking when I said that.
But
Um,
that you're in the hot seat,
no,
okay?
I think the point there is that we should have the ability to provide feedback.
Yeah.
And so if I ask somebody if they like the EHR, they like this workflow, then they have the ability to be like, yeah, this is good. Or most commonly, they're like, oh, there's a problem. And
Sure.
then I think our job, like on the informatics side, is to figure out like what's a fixable problem.
Sure.
And so in the past, sometimes you would look into something like, okay, it's this way because somebody built it this way, or that's the way the foundation system is. And there may be some reason we can't make an edit there.
Yeah.
But I think especially with the AI tools, you should be able to provide that feedback and have that go to the right people. Especially when you look like a lot of my time now is in sort of other terms. We're inventing terms today. So AI medical summarization, so AIMS,
Aims. Oh, I like it.
and then AI data extraction, AID,
Aid.
AIDE. So AIMS to aid the physicians, and
I like
providers,
that.
APPs, and everything. But I think it's knowing like, okay, if there's something that's not correct, and so we had those conversations pretty early on with a vendor, like, hey, I want to be able to provide feedback right away, and they said like in real time, okay, do you want like a thumbs up or thumbs down? Like, yep. And then like, give me a place to give a comment. And then does that go to a human person?
Sure.
And that's the workflow we have in place with that vendor, where oftentimes same day, they are reviewing the feedback. And then what we're learning, and I think isn't super intuitive to people, is that if there is an inaccuracy, it might be bad robot, bad algorithm, or it might be bad chart where the
Sure.
data in the chart is really ambiguous, or it could be a combination. And so I think that feedback and kind of closed feedback loop is really important to be able to say like, hey, it said this patient had diabetes. And then I flagged one and I'm like, this patient doesn't have diabetes. And then they responded and said, well, actually this family practice note from a year ago says they have it, and so that was one where the algorithm or the model is really surfacing what was in the chart,
Yeah.
and then you can sort of fix that and know it's up there. And so I think that's a big part of as these AI tools roll out is like, okay, if I provide feedback about this AI tool, does it go to my team locally
Sure.
who can't control it? Or does it go back to the vendor who sometimes like
Doesn't have time.
they can
Yeah.
they can make a fix sometimes really quickly,
Okay.
or they can adjust the model, or they can point out where it actually there's a reason
Yeah.
that
It is
it
that
said
way.
that,
Yeah.
and so I think when we're trying to keep an eye on maximizing the valuable time of our local informatics resources, we don't want our people responding to feedback that they have no control over, when that could potentially be on the vendor side.
Yeah.
And we still want our people to know the tools and know the limitations when we're doing elbow to elbow support, and teaching about, how people can improve, to have the system work for them. We still want that, but from a little literal, like who is seeing this message?
Yeah.
It's different depending on where it goes to. You want to have the person who can control and fix it, be the person like getting the feedback.
Yeah. No, that's a great point. Okay. So kind of in that same vein, you and I we're both really obsessed with digging in the chart. I probably would have seen that diabetes from 2 years ago, like, I mean,
Yeah.
I say that facetiously, but that's just kind of that internal medicine, informatics brain. But you're not an internist. That feels very hospital med-esque, but that's
No,
okay.
urology is like the internist of the surgical specialties because we are
Ooh.
dealing with patients that are clearly older and they have comorbidities. And so I learned like really early on, like, okay, I'd send somebody to cardiology for an evaluation and they would quote American Heart Association guidelines. So
Yeah.
I have my smart phrases for .AHA guidelines. And so I'll ask people, what they can walk up and down a couple flights of stairs. And if they have this or this, and then I'll know like, okay, like this person is safe for surgery
Yeah. Over
versus not.
formats.
Yeah, exactly. And so, yeah, we end up doing a lot of medicine, and like
Yeah.
I think everyone in a certain age group is now on blood thinners, and so we are constantly thinking about when do we stop something, when do we restart it, and that's a funny example. Like when I was in fellowship, I took a statistics class. This was at Washington, St. Louis. And so it happened to be taught by Brian Gage,
Mm.
who came up with the CHADS
Okay.
criteria. And so like, oh, this is from a multivariate model. This is how it works. And so one of my common like weekend rounding questions that the residents had no idea was coming would be like, oh, I'd wait till somebody had AFib, and then I'd ask them like, okay, how do we stratify their stroke risk? And most of the time, sometimes they would get to that, but then I'd be like, okay, well, how would you actually calculate that? And that's where people would be like, oh, I'll go and I'll find MD Calc or I'll find something. And so I have a smart phrase that's like, CHADS criteria
Yeah.
and then stroke risk based on different scores. And so then now the tool we have, if you bring that model in, it actually pre-fills the stuff that it knows. And then the stuff it doesn't know, you can click and you can calculate like really quickly,
Yeah.
CHADS criteria. And then, so those sort of things where, actually you don't think about it a lot, but like there are some surgical complications that happen from restarting anticoagulation too soon.
Yeah. No,
When
100%.
and potentially unnecessarily.
Yeah.
And so we would see a case like that maybe like once a year, or maybe sometimes more,
Yeah.
where you actually end up protecting the patient and protecting yourself from complications by knowing the medicine side of things.
Yeah.
And so I think these sort of tools, um, you know, um, not like my brother's orthopedic surgeon, and they're smartest people ever. They published a paper, that's out there that like ortho patients do better if they're managed by hospitalists afterwards, and then that's brilliant, But like for us, we have so many patients that are in and out of the hospital that it's not realistic to like entirely depend on hospital service. So we
yeah.
want to be able to make that more efficient, especially like a lot of my patients may come from an hour and a half away,
Yeah.
and so if I can save them a trip, or save them multiple trips, then that's a big thing.
Yeah. I'm all for co-management, but it's all about resources, right?
Yeah. Do you want to co-manage when the person's going to be out of the hospital the next morning, 11 in the morning?
I'm going to edit this out, but
yeah.
I do that.
All right.
We do it all the
All right.
time.
So
We got to take that out of here.
yeah.
Okay. You said you do things daily that would have been sci-fi when you were in residency.
Yeah.
So flip that. What's still sci-fi that you thought we would have had by now?
That's an interesting question. I think that like with the tools we have in place now, like I'm almost in that like futurist role where I'm like, okay, I can make a summary, I can get all this stuff out. And there are a few other providers like at our place that are running with that. We have a transplant surgeon that's super active. And so in that space, I actually have access to a ton of what I want to do. One of the things that I've seen piloted and sort of have talking to folks is like, can we make the chart more visual? And so if you look now, there are amazing ability to make like infographics about whatever you want to do. And so for a while, I have like drawn the pictures that I draw with the patient on the iPad in Canto, and then it'll take me 10 seconds to screenshot that and put that in the chart.
Nice.
And so I wouldn't necessarily expect it yet, but I think like you could say like, oh, is it make sense if like my mom has like an infographic of her medical care?
Yeah.
And so I think that's something that I wish was maybe available, in the near future.
Yeah.
The real BS, stuff is like insurance companies denying diagnoses that people clearly had.
Yeah.
And so some of that like really should have gone away when there are some clear like sources of truth. I work a little bit with our hospital and doing inpatient claims denials too.
Hmm.
And so there's some crazy stuff that happens in that space that there's not an accountability on the insurance side to be like, okay, this patient meets these criteria for this diagnosis. But then on the provider side, we're not like 100% accurate.
Sure.
Where when I review some of those cases, I still on occasion will be like, oh, our providers didn't support that documentation
Sure.
enough, or maybe there's chart lore where something was in the chart or
Yeah.
on the problem list
Sure.
that wasn't necessarily applicable to that. So I think you run into that. Like there should be a real source of truth for patients, for different diagnoses. Do you have this or do you
Do you
not?
not?
And
Yeah.
so to me, it's a little crazy that we don't have a better ability to be like, all right, if somebody objectively looked at this chart, this is true versus not true.
Yeah. I mean, and again, I know we were talking about Epic. To me, when I think from an informatics standpoint, do you guys use the problem list and the medical history? Do you use
So
both of them?
so we use the problem list,
You
but
don't
not
you don't like
the
auto.
the medical history exists, but there was a choice many years ago to kind of work around the problem list. But I
Yeah.
think everybody says the same thing, or the problem list is a problem,
Yep.
because
Uh-huh.
and we actually have chosen on our inpatient service because we're such rapid volume for patients that we will chart a number of things just as text within the note.
Yeah.
Because if it's hypokalemia, I can type or dictate hypokalemia, potassium was 2.9 repleted with 20 milliequivalents KCl, and then I can move on.
Yeah.
Versus if you're adding that to the problem list, documenting within the problem list, and then later removing it,
Yeah.
you may be doubling or tripling your amount of
Your work.
time. And then,
And that's a great example of but a systems issue or a workflow issue
yeah,
outside of the it is technologically related, but it's actually, you know, what we're physically doing
yeah,
to the computer, you
mhm,
know? And I think that, yeah, it's so important for teams, for institutions to be closely looking at what providers are doing on a day-to-day basis and saying, we don't need to automate this because we just don't need to do that anymore.
yeah,
Right?
yeah. And
What
it's
can we
it's sort
take
of like
out those kind of silly things?
what's the pebble in the shoe,
Yeah. Yeah.
stuff that's bothering people, or what's that headwind blowing into you that's making your job harder than it needs to be. And I think you see it on the outpatient side too, where people have an expectation that you still need to document, 10 review systems, 8 system exam. If those things are not applicable and they're not part of medical decision making,
Yeah.
that's probably the most common thing that I delete is somebody will say 10 system review systems was negative. And I'll be like, oh, like, really? Was it?
You did the whole thing.
Yeah, like
Yeah.
I'm
Yeah.
like, all right, what were the 10? And there's some of that that we know existed because okay, this patient got a patient questionnaire
Yeah.
and it's all there, and it's absolutely true. But then there's some other times where you're
Sure.
like, all right, we just need to document like what's important,
Yeah.
and what's relevant to that patient, and so those kind of challenges actually got better. But well, does everybody actually know what the rules are now about what's necessary?
Yeah.
And not everybody does.
Yeah. And if you're designing something when you don't know the rules, where are we really designing to?
Yeah,
All
yeah,
right, two
absolutely.
more questions.
All right.
Dr. Ken Nepple on the Health Tech Hot Seat. What's one AI hype that you're calling BS on?
Um, everyone being able to read the whole chart like
Mm,
right away. And so, I think like there's lots of ambient. I thought I was not going to be a fan of ambient, and then I started using it, and I use it like on every patient. I don't use the output on every patient, but I use it all the time. And so there's this discussion that really quickly all these different either ambient companies or vendors are going to move into being able to summarize the whole chart. And so I think that is harder than people realize.
hmm.
And, the whole chart includes the foundational data, but also the health information exchanges, also the stuff that's in the scanned and fax records. And so from doing some evaluation in that space, like we found out that basically 5% of our data is in the scanned fax records. Like 22% of the data is in the health information exchanges. And
Hmm.
so
Hmm.
if you're only looking at foundational data, you're missing about 25 to 30% of the chart. So for us, that's huge
Yeah.
because that may be the very important pathology report. It may be the very important radiology report. And so I think with that, the bubble kind of bursts on like, is all AI the same? It's not. We know that from using, different tools. But then, can you do something at scale and ingest literally millions and millions of records and billions of words,
Hmm.
and do that in a way that is financially responsible with token
Yeah.
usage? And so I think that there's been an assumption that because somebody has access to the data, that they can make a summary from the data,
From all of it.
because there are some steps involved with that that are a little harder and require some real AI expertise, that you're not going to just put a wrapper on a large language model and be able to be like, oh, this does that.
Yeah.
So AI, like, it may be a expert in like Shakespeare because it's seen everything that Shakespeare ever wrote, and it's seen all of these discussions of Shakespeare in the training, but it hasn't seen all this medical record data,
Mm.
and it's clearly not an expert in like cancer, and
Mm.
specifically in this, type of cancer. Like, it can do pretty darn well, but in that evaluation we're doing, we still see some gaps where it ends up being like, oh, this is a super complicated patient. And it turns out they, rather than having a prostatectomy, they had an aborted prostatectomy.
Mm.
And
Okay.
so if I tell you that, they didn't have the surgery, but the LLM may get confused about,
Yeah.
it said forever they're going to have a prostatectomy. And then after that, it said they had an aborted prostatectomy. And does it know the negation
Sure.
of that? And so that's an example where like we as providers need to be like involved and
Yeah.
be like, all right, like all we need to do is to then feedback to the group that abort it in a surgical context,
Hmm.
means that surgery didn't happen.
Yeah. And negates
uh
that prior
yeah,
information with an updated,
yeah. And so
yeah,
we're like, okay,
pictures.
like the reason that these things are not 100% accurate is you have case examples like that are really, really specific.
Yeah.
But then you also, I talked to somebody earlier in the meeting about like, okay, for cancer registry abstraction, like how accurate does it need to be?
Hmm.
And the concept is like, it should probably be pretty darn close to 100%.
Mm.
But when we look at our humans, locally we have like maybe a 1% to 2% error rate, but they said when they looked at their data in a different place, it was more like 3 or 4%. And so there is an element of like, okay, how good does the AI have to be?
Sure.
I think if it's roughly equivalent to human abstraction, then that's pretty darn
Yeah.
good. And we
Yeah.
want it to be close to 100%. But I think there's a tendency to maybe make put the bar higher
Yeah.
because it's a computer algorithm, versus like, and there's some stuff in the cancer world that provider abstraction is only 70% accurate. And so it's like, well, the human part is not doing amazing to
Not
start
doing
with.
so hot. Yeah.
Yeah,
Yeah.
yeah. So I think there's all sorts of specific examples like that where like we need to engage as providers to be able to say like, all right, this is how we get from 90% to 95% to 99%, in a relatively rapid fashion. If you can feedback and say, okay, these are the other rules. And then, the whole thing when we're benchmarking and doing all these analysis, like we just got done manually reviewing with our research assistant like 4,000 different data points. And we learned a ton from that because we would talk back and forth about, okay, if there was some inaccuracy, why was that? And we'd look at the chart and look at the chart. But then at the end of that, it's like, well, why does that matter? And for us, it was really clear, well, we can improve our prompts that pulled that data out. And then we can also work with the vendor to provide some feedback to either add some additional data points that don't exist in any model right now, that
Yeah.
don't exist on any ontology, no matter how comprehensive that is, to be like, okay, this is something really, really specific in this cancer. And then, you can actually make it better. So
Yeah.
it's almost like, everybody talks about QI, but you want to do like QI for the EHR,
Hmm. Hmm. Yeah.
and it's not
Absolutely.
just process, but it's like, all right, this machine can get better
Yeah.
in a much faster way than it's ever been able to in the past.
Yeah, and how do we create solutions that enable teams locally to do just that, make
Mhm.
the EHR better for patients?
When we have put out this concept, we're,
Yeah.
we're really having to explain to people like a new model for doing research and
Okay.
in quality improvement, you know. And so
Okay.
what I'm now working on doing better and better each time we write up something like this, it's like, okay, this is not like an Iowa proprietary thing. You
Yeah.
know, it's like if we have these rules and these prompts and this information, then that's something that can be shared with other places. So that if a vendor starts doing this, or some other group starts doing this, or there's clinical trial matching software, you can all develop like this library of basically coding, you know.
Hmm.
And so
Hmm.
in the programming world, people are sharing stuff on GitHub,
Yeah.
and then you know Stanford, some other places will do that now with health informatics type stuff.
Sure.
We're like, all right, that's the model in the future. Is like, okay, we figured this out, then we can share that so that it's not just something that impacts our system, but then you can take those rules and you can apply them in whatever computer, you know, AI version you have, and not have to start from, you
From
know, square one,
scratch.
from
Yeah.
scratch.
Yeah.
Yeah.
Absolutely. Well, this was Dr. Ken Nepple. Hey, thanks so much, Ken.
Hope you enjoyed today's interview on the Health Tech Hot Seat. We'll see you next time.